would say, what is mild forgetfulness versus more of a serious problem? So there is a significant distinction. Part of normal aging, for example, you might occasionally forget a person's name and then recall it later, or forget or misplace an item. Glasses are common, and it might come back to you later. There's one thing to have a lot on your mind and be kind of distracted and then come back to something. It starts to become concerning when there is a disruption in functioning. So normal aging, I would say, is where there's no interruption in terms of you're able to function day to day, take care of your affairs, finances, make decisions, organize appointments. I would say it becomes more of an issue. Dementia or memory loss becomes more concerning when there's a pattern, or that there's interference. You're not able to complete tasks that you were normally able to. And making note that dementia is not a normal part of aging, and it's not a personality problem either. It is a disease that has to be faced with. And we are working on, we're going to be talking more about it as a disease. And I like the example I say with memory loss that, when you have a cold or even the flu, you've developed a repertoire of how, there's no cure for a cold, right? There's just ways to alleviate the symptoms and be more comfortable, but you're able to navigate that. And dementia is kind of the same way. It's not a cold, but the idea is we develop a repertoire to be able to cope and manage it. So any kind of questions about normal aging versus a serious problem? So I love this visual. You'll get it. Really the main red flags are issues with finance, issues with judgment, difficulty with language and conversation and social cues, and just noticing significant changes that weren't there before. Okay, I'm going to keep going. Hold on, let me reshare my screen. Okay, so diving into kind of what is dementia. Sorry, here we go. Can everyone, if you can't see something, let me know. So dementia is an umbrella term to describe a set of symptoms or condition. It is a global deterioration, and it happens to include memory, but it's not just memory. It refers to kind of neurocognitive diseases, and it's global in nature. So memory is just one aspect. Judgment, reasoning, language, personality, problem solving, these are all part of the dementia. And so it's more of a global term to describe the symptoms. So I think thinking about it as an umbrella, it's an umbrella term for loss of memory and other thinking abilities, and interferes with daily life. So then we're going to get into the types of dementia. So when it comes to kind of approaching a situation, dementia is a great term to use because it's just all encompassing of all memory disorders, neurocognitive disorders, not just one. So if you're experiencing memory issues, dementia is the correct term to use, because we're going to start to get into diagnosing, and that's where there's a lot more intricacies. Alzheimer's disease is the most common form of dementia, making up 60 to 80%. And then it's actually vascular dementia, then Lewy body dementia, and frontal temporal. And then you get into the others, which are Parkinson's, Huntington's, mixed dementia, other forms, but we're really going to focus on the main 4. And tell me if you need to slow down or clarify. There's a lot of content here. So again, to highlight, I'm going to be pulling up this other visual that's a fantastic handout. So really looking at Alzheimer's disease, vascular dementia, Lewy body dementia, and frontal temporal dementia. And they all are different. They might have overlapping symptoms. So let me just pull up, I like this handout to start to dive into the different types. So if you have specific questions, and I have a slide for each one, so we can kind of see what's the best format. So let me just switch gears. Okay. This is and these are my go-to handouts, like so this is like very, this is put out by NIH. Okay, so types of dementia. So we're going to start to go through, there's this, I like this handout because it's going to go through what's happening in the brain, the symptoms, the age of diagnosis, and then we're going to go through treatment. Okay. I'm going to go through it one type at a time, focusing. So let's start with Alzheimer's disease, since it is the most common. And I can even like try to zoom in here on the images. I think the use of images is really important so you can see what's going on in the brain. Here. Okay, so really what's happening with Alzheimer's disease is the way the brain communicates. So there's an abnormal amount of protein that forms in the plaques and tangles of the brain. And this is what the brain uses to communicate. And what happens is the buildup of the protein really end up interfering and stop the communication, stop neurons from communication. So it's basically a lot of blockage is what's happening in Alzheimer's disease, is that there's an increase in protein. And we'll start to get into this in diagnosis, because the cornerstone is the protein buildup in Alzheimer's disease. So this is going to carry through the symptoms and then how it's diagnosed too. So the plaques and tangles, there's really an excess amount of protein. And, we tend to think about Alzheimer's in stages, kind of the mild, moderate, and advanced, and starting to see the different symptoms depending on what stage somebody is in. So maybe, mild might be more a lot of repeated questioning, maybe some of the behavioral symptoms of agitation, confusion, and then getting into more of the behavioral symptoms of like wandering or disorientation. Moderate problems, I would say moderate to advanced would be like recognition of people, close family or friends, and language issues. So a lot of challenges with communication. You might see a lot of aphasia, and some of the symptoms. And then the age is mostly mid 60s and above. That's standard. And we would say early onset is in the 50s. So if it's under 60, you would have early onset. And then I'll go into, do people want to hear a little bit about like treatment? Okay, great. So let's start to get into kind of the options. You know what, I'm going to go back and forth. I hope it doesn't drive anyone crazy. Tell me if it's like too much. If it's too much, going back and forth. Okay, so here's Alzheimer's disease. So let's start to go through a little bit. Oh, I want to be very mindful of the time. Okay, let me just be very mindful because it's going fast. Okay. So really there's no, all these neurocognitive diseases are progressive. There's no cure. It's really looking at medication, managing symptoms. And the medication, we know there's a lot going on in Alzheimer's right now. The most common is like a cholinesterase inhibitor. These are the Ariceps, Exelon. They're the most prescribed drugs. They basically are to improve brain communication, but they're basically a way, what happens in the drug is they create like a distraction that interferes so that it slows down the progression. So when you're on a medication, somebody is able to remain at a cognitive function that they would have been at 6 to 12 months previously. They don't cure, they just help or reduce some of the symptoms. They really just slow down the progress very gradually. But there's no modification being made. So there's a lot of talk now about the new drug that's on the market, and it's the only medication that actually targets the protein build up that can modify the disease. So most drugs on the market don't modify the disease. Okay, so let's go into vascular dementia. So this is the second most common. What's happening in the brain is it's produced by, it's not necessarily produced by strokes, but basically there's a blockage in the blood flow of the brain, and the disruption in the blood flow basically can cause dementia. It's basically like the brain is not getting enough blood, and it can result in many, a stroke or small strokes. And a stroke isn't always what causes it. It could just be a combination. It's really even a damaged blood vessels or reduced circulation. So symptoms of vascular dementia really include, we're getting into more of like hallucinations and delusions can be present, judgment, and not remembering current or past events. Vascular dementia has a component of managing lifestyle, manage diabetes and other types of illnesses. High blood pressure will help them be preventable or manage the dementia. And it's usually age of diagnosis is over 65. And then we're going to get into Lewy body dementia. So what's really happening in this situation is Lewy body is a combination of the dementia and I guess, well, that's more getting into the symptoms. So let me just like back up to, hold on, let me see here. So, oh, wait, did I stop sharing? Hold on, can everyone? Okay, can everyone see this? Is this where we were before? I'm sorry, I might have like lost track. Okay, so what happens in Lewy body is again, a change with the protein. So There's abnormal deposits of a specific type of protein that are called the Lewy bodies. And the protein specifically impacts the brain's chemical messengers. So it's going to be different than Alzheimer's because that's like a complete blockage. This is going to be maybe more altered messaging compared to Alzheimer's disease. So that's why, unlike Alzheimer's, with Lewy body dementia, there's more of a Parkinsonian's-like feature. There's more, the cornerstone of the symptoms are really the dementia and the movement disorder. So symptoms, the cognitive, movement, sleep disorders, and visual hallucinations. And it's, all of these are really hard to manage. They're very complex, and we'll start to get into a little bit of more of that. And then there's frontal temporal dementia. So frontal temporal dementia, there really is, it's a different, again, there's a protein that accumulates really specifically targeting the frontal and temporal region, versus Alzheimer's, the memories are impacted by like the hippocampus. So it's this is a different part of the brain. So it's really, the frontal temporal regions are really impacting executive functioning. So the symptoms are going to be more targeted to social emotional symptoms, kind of regulating social cues, difficulty with functioning, judgment, and reasoning. There's an impulsivity or excessive emotions. So frontal temporal definitely has an personality component as a symptom, and language. And this one, treatment is really difficult because the same medications used to treat Alzheimer's don't work with frontal temporal. So it's not the same medication that's used to slow the progression doesn't seem to be as helpful for people with frontal temporal dementia. It's really focusing, but there are certain medications to manage symptoms, and a big push for clinical trials, antidepressants, antipsychotic medications, and a lot of speech therapy to try to combat it. And I like this visual because it would actually change a little bit of it, but we'll work with it for now. This is a great visual of how disease, while they're all progressive, they're not linear. Okay, no line is like a complete straight line. So thinking about it in terms of like where we're at, like you can see here, Alzheimer's disease might be the most linear, but even still, it might be a steady decline, and then there might be more of a decline. And then there's vascular dementia, where it has the stability, like the decline in a plateau. So like it could be years, like you could be really have a sudden decline and then you kind of plateau. And dementia with Lewy body is a little bit unpredictable in terms of how, a sudden decline, like maybe that's why with Lewy body, there might be more hospitalizations. Alzheimer's disease, there might not be as many hospitalizations, but Lewy body, because of some of the suddenness, it might require more hospitalizations. A sudden turn, maybe there's a bowel obstruction all of a sudden, or issues with toileting that causes sudden decline that isn't necessarily common in the other dementias. Okay, how are we doing? Want to check in. Any thoughts? We're going to start to transition a little bit. I wanted to kind of like go through the types. Any like questions? We're going to keep going. We're going to start to transition now into more of the assessment and diagnostic portion.
Melissa, I did notice 2 questions in the chat.
Oh, sorry. Thank you. You know what?
I didn't know if you want to wait for the question and answer portion, or if you want to answer those now.
Should we, well, it's up to you.
Okay, I think you can answer. One asked about what is the medication. Earlier you had mentioned that there is a medication that is more so being used as treatment, and I think someone wanted to know what the medication was. And then someone also said it would be nice to have an overview of each assessment before getting into treatment. Okay.
Okay. I'm sorry. This is what happens. I appreciate your patience. I'm sorry. The dog. I might have to let her out. Okay. So the question's about the medication. So wanting more information about the specific types of medication available for Alzheimer's.
Eleanor, could you elaborate on what you meant by that? What is the medication? I believe that they were asking about, you had mentioned that there was a type of medication that was being used as a treatment.
Okay, so there's,
they were asking about.
I think I could clarify. So there's kind of now there's 3 lines of treatment. Okay, so think about it. So I would say I'd break it up into like mild to moderate. So the treatment for most mild to moderate Alzheimer's is a cholinesterase inhibitor. The goal of this treatment, so that's the type of medication, what the medication is doing. The names of the medication are Aricept, Exelon, and Razidine. Hold on, let me just see my notes here. Okay. And so I have a lot of notes. So, so basically the goal of these medications is to improve those communications with the plaque and tangles. It's to improve the communication that's impacted by the disease. So basically what happens is when there's an excess of cholinesterase, this basically creates a noise in the brain. So communication can't happen. So these types of drugs inhibit that noise. It basically quiets the noise so that you can remain at the same cognitive functioning. It doesn't stop the disease, but it makes the progression more gradual. And then when you get into more moderate to severe, then we're talking about memantine. And memantine is it's an NMDA antagonist. So it's used to treat, really to focus on the symptoms and really look at functioning. So for example, memantine might help someone in later stage disease maintain your ability to use the bathroom independently for several months. So it's just how the medications are used to slow the progress or the target. Okay, and the third thing is that is the new medication. I'm going to mispronounce it because I always do. The aducanumab is the only disease modifier right now. So both of the cholinesterase inhibitors or the NMDA antagonists, they're not modifying the disease. Okay, I can spell it. ADUCANUMAB. And I have a great visual. I'll share it with you if you're really into managed symptom. Here, let me share this. And it is through an IV. It's the one that they're talking a lot about where it's very expensive. So here we go. So this is I really like this chart. It's through I'll make sure to share it, but basically, I love how it goes through the type of drug, how it works, and then the common side effects. So this kind of lays out all the different options. So that's how I'll make sure to share this image with you. Yes, there's questions about efficacy. Yeah, but it has been proven that it does. It's the only drug, it's the only drug actually modifying the disease. Yeah, so what I'm going to do is share all my PowerPoint and handouts with Ari, and then he will share them with you. Okay, so are we good to kind of move on? And I'm not a doctor, so the best thing to do is to consult with your doctor. The medications come in different forms. So sometimes it's a patch, sometimes it's a pill, sometimes it's an IV. So it's, especially if there's behavioral symptoms, figuring out which type of medication in which form, it's critical for med compliance. Let's start this transition now for testing. Okay, so we're going to start to get into testing and diagnostics and like what to expect. And I think there's probably a big interest in this area. So first and foremost is there's a lot going on with our bodies. And, before we reach a dementia or a diagnosis, the goal is really that dementia is not reversible. Okay. But of course, there are many factors that, especially with the symptoms, if you are experiencing a symptom of inattentiveness or confusion, or some of the symptoms could overlap in a lot of ways. So the first thing is really, of course, just to rule out any reversible conditions, because this is very positive. So especially things like vitamin deficiencies, hypothyroidism, metabolic disorders, infections such as UTI. There is a difference between, most people have, think of a UTI and symptomatically it's a cornerstone if there's a lot of delirium, and that's a very reversible condition caused by an infection. Alcohol or substance use. I have seen this in a lot of client situations if there's a history of alcoholism. And there is a link with alcoholism and vascular dementia. Medications, side effects of medications, head trauma or injury, and sleep apnea. These all really contribute. These are all reversible conditions. So I want to put that out there, like first and foremost, it's not always dementia. Let's rule things out first. And then let's start. So the first thing before going is to indicate if there is actually a memory issue. Like, let's first figure out if there is a memory issue before going into what type of memory issue. And this can be done, I'll start to get into it more, is through, can be done with a primary care physician, geriatrician. It might be at the point of a neurologist, or a social worker. So let's start to get into spending some time on the types of just assessments that are usually most often done. So there's the MoCA, this is the most common one, the Montreal Cognitive Assessment, the Mini Mental State Exam, and then the Mini COG. Okay, so the MoCA usually is best for identifying mild cognitive impairment, early on. Just to tests only determine if there's a memory issue. They don't diagnose any. The memory assessments don't do any, they don't tell you what you have. They'll just indicate, yes, there is a memory and thinking impairment. And then the next stage will be diagnosing. The MMSE is better for more serious cognitive problems because there's a lot. I'm going to have visuals, so I'm going to show you each one because there's more threshold to it. So it takes a lot more to go. It's hard. It's an easier test. So because it's a little easier, it takes more for it to indicate something wrong, okay? And then the mini cog is quick and easy. It's most used by providers. If you go in and they ask you a few questions, they're giving you the mini cog. If they ask you 2 or 3 questions, repeat a few things, they're probably giving you the mini cog because you don't really need a pen and paper. Okay, so I want to show you. So, and focusing, what's really important is looking at what the assessments look at. So they're domains. It's really looking at all the, not just memory, it's a combination. So this is the MoCA, and I will put it out there. There is a MoCA blind that's used for telephone. So, and I've administered hundreds of memory assessments. When I was with the Club Memory program, it was every 6 months to everybody who is involved. And I want to share a little bit of a case, if it's okay to go over like 5 minutes. I can give you an example. I think it'll be helpful, but this is, and it's important to note, it's out of 30, and anything 26 and above is normal. So anything below 26 would indicate some sort of impairment. So the scale is really, and there is overlap. So really like 18 to 25 would be a mild impairment. 10 to 17 would be more moderate. And then 10 and below is severe cognitive impairment, but there's not enough research in that area. Let me zoom in a little. Would that be helpful so you can like really see it here? Can people see it? Does it look good? Okay. So this is what it looks like. I think looking at an example. Let's look at an example, case example of one. Can people see it? So I want to kind of go through with you like what I see when I look at it. Okay. So this is a case example, a real one. And I will note with all memory assessments, there is just to like put a disclaimer, like I have to like be politically correct here, that there is an education is a factor. So if looking at education so that's why you ask education level, because there's a different scale depending on education. And the MoCA has been translated into about 35 different languages, but there's, variant in terms of cultural. So I just put it out there. So this individual did really good on the first kind of visuospatial task, orienting, and then wasn't able to do the copying of the cube. But I really want us to look at the clock drawing. From a clinical standpoint, the most indicator, the area with the biggest indicator is going to be the clock drawing and delayed recall, the memory. Those two things have the highest like intel from a provider standpoint. So this person, and I'll show you some other clock drawings. They it's looking at the whole thing about the clock. Okay, is it in the right order? Are all the numbers present? And is the hands in the correct position? Okay. And so this person did get it, but there is some Parkinson's like symptoms happening because you can see with the shakiness of the writing that this person may have some Parkinson's. And then going into, want to focus more on the memory. Okay. So you kind of give the memory test, then you give some distraction, the other portion. And then down here at the bottom is where you ask the person to recall the words that were shared. And you can see here, this person didn't get any of the words. So they did get the clock drawing, but there's a memory component that they got 0 out of 5. Okay. So this person scored a total of 20 out of 30. So that's indicating some moderate, that this person definitely had some sort of dementia diagnosis. The dementia is present. We don't know what type. Okay. And then I'm going to just breeze through that. These are the other types of assessments. This is the Mmse, what it looks like. It has a larger scale. Normal, again, is 26 to 30. Same kind of scale. It also looks at the same things: orientation, memory, language, abstraction, and then the mini cog. This is, and it's brief. It's basically asking you word recall and the clock drawing. So let me show you clock drawing. And the time is set like 11 past 10, or no, 10 past 11, sorry. Like 10 past, like a practitioner would give you the time. So you can see what normal is. So this might be 10 past 6. I wish these were all the same time. These were all the same time. So you can start to see the progression. Okay, this is what typical looks like. Okay, mild, we start to see some like orientation, spatial reasoning, you know, where the hands are placed. And then the late stage, not really having any orientation at all. Is this helpful? What are people thinking? I don't want to lose people. So I hope I can. I'm like, look, let me see. I don't want to lose you all. Is this stuff you know? Is it new? Not interested? Okay, great. Okay, so let's get into, now that we've established, okay, our client, here's our client, Miss R. We've established we do an assessment, social worker does an assessment, indicates, yes, there's dementia. Let's get a follow-up and see what's going on. So let's get into like the neurological testing, okay? And some of the assessment could happen during this, will happen during this portion too, okay? So this might start with a physician or a geriatrician, and they might refer you to a neurologist. And that neurologist might have a team of a psychologist or psychiatrist. And let's start to get into the diagnosing. There's been memory concerns. We want to figure out what's really going on, okay? And there's no one test to determine, like there's not a gold standard. It's a combination based on like ruling things out and really working to what the symptoms are in combination with diagnostics. So looking at a comprehensive medical history, if there is a family history, physical exam, this is where like movement will, would play a role, lab work, and then brain imaging. So when you go, if you want a memory assessment, you need to advocate that you want a full workup. And this is what a full workup includes. And really to go back to like a lot of the proteins, this is where an MRI or CT or PET scan is going to come into play, because, for example, in Alzheimer's, the imaging of MRI or CT scan are used because they would be able to identify the proteins. Or even, if there was another condition going on, that would be able to rule it out. And doctors vary in their level of liberalness and conservativeness on how much they want to give a diagnosis. I can say from experience, if Kaiser is going to be more conservative. A doctor's not going to want to diagnose Alzheimer's, because technically you can't diagnose Alzheimer's until someone dies and opens up the brain. So it really depends on the provider in terms of how liberal or conservative they are in terms of some of their diagnosing. So, and lab work and identifying symptoms are really critical. A lot of doctors will diagnose dementia and may not diagnose a specific type. That is a common, that does happen. So making sure you get a second opinion is really best practice. Questions about neurological testing? Okay. And I have a great, I'll share, we have a great fact sheet on referrals resource for testing. And I own a resource that I can share with you all to make sure. Okay, so now that our client we identified, has some sort of dementia, and then she goes to a neurologist where the neurologist orders blood work and MRI, maybe some specialty MRI, and maybe they meet with a psychologist, and that psychologist is going to do a battery of tests. Many of them some of the same assessments, some IQ tests, a whole battery of other tests, and the psychologist will also make care recommendations as well. Okay, so now we're going to get into what happens afterwards. What does it look like? Why is it important to have a diagnosis? And this is very personal. Some people really want to know and some people don't want to know. I will always be from the camp of wanting to know because it does impact so many things. So what's next? There's a lot to think about. It's not just getting a diagnosis and now you have a diagnosis and this is what it is. It's starting to take inventory, I think, in a lot of areas, figuring out medication management and clinical trials, really important. Clinical trials are so critical, especially in this area. So being able to try to that really happens early on, you're more likely to have a broader range of clinical trials. And really to be a part, getting a diagnosis so you can still participate in the care and making decisions. And what really comes next is organizing your own affairs. Really, why it's important is because it's basically indicating that there's going to be a decline in you to try to figure out, manage your affairs, organize legal and financial matters so you can have the best care that you would want. And determining future care preference. And also the idea of setting up a care team, like figuring out what resources and supports are available. So I will put it out there, like in DC, we have the Club Memory Program and Dementia Navigators who are specialized in memory-related issues and long-term case management that will help navigate a lot of this. So that's kind of like the bulk. I'm happy to go over other things. I want to check in if there are questions or experiences or situations you want to kind of run by. I want to just kind of get a temperature check of the room here.
Okay, and I'm going to stop recording now so we can open the floor for question and answer.
Oh, wait, there's a lot of comments. I'm sorry. I can't multitask. Okay.
I think you already addressed a couple of comments that were specific questions. I think the one that I'm noticing that you already addressed is, I think this was already addressed about what is the name of the medication. It's a new medication.
Yeah, let me put that in the chat. I'm really not good at pronouncing it. this is it.
And Wendy mentioned that her
Oh,
understanding is that
yes.
the new medication
Mhm.
for Alzheimer's is controversial because of the efficacy is questionable at this point.
Yeah, I would agree. I mean, like, you know, I'm here to share what's available, like anything else, you know, this is the first of its kind. So, I would say if you are a candidate, like, you know,